All right, thanks everybody for joining us today for Mini Grand Rounds. Aaron Friedberg's joining us, and he's going to give us an update on the latest guidelines on colon cancer screening.
All right, well, thanks everybody. I wanted to talk about this important topic. There was a new update by the U.S. Preventive Services Task Force earlier this year, and called the talk taking a broader scope because part of the guidelines are expanding what we should be doing in screening. I wanted to make sure we all know about this important topic. Certainly this is an important thing. Colon cancer is a major issue in terms of cause of cancer, number 2 in the country in terms of cancer deaths, and there are things we can do to help with this. So for this talk, several objectives. One is to make sure we know the different options for colon cancer screening that the USPSTF recommends, and also to know which resources you can use both for yourself and for your patient to educate, inform, and make appropriate clinical decisions. So let me give you a few cases. We'll come back to these at the end to try to figure out for these different kinds of patients what we should be doing for them. For the first, we have a 58-year-old African-American male with a history of diabetes coming in for a physical who's never had colon cancer screening. Next is a 76-year-old white female who's had colonoscopies every 10 years starting age 50. Next is a 78-year-old Native Alaskan male who's never had a colonoscopy. And finally, an 86-year-old Southeast Asian male coming for physical who's had a total of 3 normal colonoscopies. So we'll look at what we can do for these different patients and more. So it's a big topic. As we talked about, 134,000 cases a year and 49,000 deaths a year, second leading cause of cancer deaths, and about a third of those who are diagnosed will die from it. Now, interestingly, the rates have been declining. I was looking back, these old papers with the old guidelines back in the 90s. They're talking about, this year in 90 it'll be like 180,000, cases diagnosed, and it's less now, and they've been declining. And there are a few reasons for this. They think that about 53% of this effect may be due to screening, which, kudos to us, right? And there may be other factors too, but this is the part we have control over. Unfortunately, ultimately, about a third of eligible adults never get any screening, and this is part of the motivation for the change in the guidelines. As far as when to do this, no major changes here, but the best age is 50 to 75. And the way they came up with this number is really based on statistical modeling on population data, looking at incidence, and basically where's your best chance to reduce mortality. For the older set, 76 to 85, there's moderate benefit, but there is more benefit if they've never had a screening before. But if they've already had adequate screening, maybe not as much. And there's really just not much benefit for people over the age of 86. But that said, they don't talk about this in the USPSTF guidelines, but in other organizations' recommendations, they talk about it being sort of a 10-year benefit. If you are trying to reduce the risk over 10 years, it may be beneficial. If someone's 86, but everyone in their family lives to 105, you might think about it. But overall, in general, not a high-yield group. Then the question is, how useful is screening? So age is the most important risk factor for most people. It's accepting, genetic conditions and other issues, but 90% of people who get this are greater than 50 years old. The mean is about 68. Let me click on the PowerPoint. Positive family history is related to about 20% of colorectal cancer. This is outside, Lynch syndrome, one of the genetic conditions, but just someone in the family having it, there's going to be a link to about 20%. And then other factors like male sex, black race also have a higher incidence and mortality. So things to think about when you're talking with people about the importance of screening. Now, I thought this was interesting, where no screening reduces all-cause mortality in any age group. I thought this was interesting because what are we doing, right? The headline on the pamphlet for getting colon cancer screening is colon cancer screening saves lives. Except it doesn't. When they do studies on it, they've never shown that it has a decrease in all-cause mortality. Now, that's a hard thing to study. If you're talking about, say, 2 or 3% of the population getting colon cancer and, 0.9%, being saved if it's a third of people, being saved, you're talking about 0.9% of the population. So that's a hard thing to show, except they tried. They did one study, I think it has 200,000 or 300,000 people. Sorry if I have to give you the exact numbers, but 200,000 or 300,000 people where, you'd think you'd see this effect, and they still didn't see it. So, what are we doing? Part of the issue is it's very hard to show all-cause mortality. There are a lot of things that go into that. The speculation on the cancer websites is, well, it may be due to an increase in death from other causes, but why would that be? Why would, if you're dying less of colon cancer, shouldn't you just die less? And I don't know. No one has a good answer there. There's some speculation about the stress involved with the screening process maybe being
some other problem with cardiovascular. Maybe a result of the screening somehow is causing other problems, but no one seems to have a really good answer for this one. So I wish I had a better solution for it. But the standard they use is, does this reduce the risk of death from cancer? It does. It absolutely does that. A variety of screening methods have been shown in randomized controlled trials to reduce the risk of death from cancer, but no one's been able to show absolute reduced risk of death. And there's a lot of speculation that really you just shouldn't use that standard, that there are a lot of reasons that might be true, and we know colon cancer screening works, so let's hope that's true, because otherwise this talk is a little pointless. But I think we know we're saving people from colon cancer. You hope it's overall decreasing the risk of death. And there may be some benefit, at least, of if you're going to die, you don't want to have to die of colon cancer. Maybe it's better to die of something else. I don't know. At least you can have some choice about that. Anyway, we'll move on to more pleasant topics, like what kinds of things you can do for colon cancer screening. So there are different types of tests that they detail in the most recent recs: stool-based, direct visualization, radiography, and then serum tests. So the stool-based tests, these include the Hemocult 2 is kind of the old one, and then there's the newer high-sensitivity Y-axis occult blood test. In terms of sensitivity and specificity, 60s to 70% on sensitivity, 80s to 90s on specificity. And then this FIT test, the fecal immunochemical test, basically this is better than FOBT. That's really what it comes down to. The best one is this one called the OC Lite, and it's got a sensitivity of 70s to 80s and a specificity just plain in the 90s, so it's better in both fronts. There's also this FIT DNA test, which was approved relatively recently. It's more sensitive but less specific than FIT. Sensitivity is in the 90s, but specificity is more in the lower to mid 80s. And quite frankly, sorry.
Oh, sorry. There you go.
They sort of don't quite know what to do with this test, and we'll talk a little more about that. For direct visualization, this is like the flexible sigmoidoscopy, the colonoscopy. So the FlexSig, probably overall it's better to combine this with FIT testing probably every 1 to 2 years. We sort of get more yield and more reduction of mortality with both together than either apart. But there's some direct harms, perforation and bleeding. But it's lower than colonoscopy, basically 1 perf or 2 bleeds per 10,000 procedures. That's 0.08% complication rate, something like that. That's versus colonoscopy, which is considered the gold standard, though, you still miss cancer sometimes, though rarely. But interestingly, there's no direct evidence that colonoscopy reduces cancer mortality. It's all inferred. There's never been a randomized controlled trial showing that colonoscopy reduces mortality. It's inferred from FlexSig studies, which makes sense. If you can see, 60 centimeters, if you can see more, you're going to do better with colonoscopy. They haven't showed it. There's the confirmed trial that's running right now that probably will show this. It just hasn't been done. As you can imagine, these are pretty long-term studies, so it's hard to get a quick result with this sort of thing. But there's definitely harms to colonoscopy from the prep, electrolyte imbalance or dehydration, cardiovascular problems like with anesthesia, and then infection and perforation and bleeding like with sigmoidoscopy. But the rate's a bit higher. They figure around 4 perforations or 8 bleeds per 10,000 procedures. Total complication rate maybe as high as 0.2%. But it's higher with age and higher if they already had an abnormal screening like a flexible sigmoidoscopy, which makes sense because the main risk seems to be with having polyps. And so if you already have something abnormal where you're likely to take out polyps, you're probably more likely to have these complications. So radiography, there's the CTC or CT colonography. And there's no really direct evidence for the success of this in terms of mortality. It's all about just the nature of the test being a CT scan. But basically, they figure if you have an adenoma that's 10 millimeters or greater, if you do PrEP, the sensitivity is somewhere between 60, some and 90-some percent, specificity is in the 80s to 90s, and without PrEP, it's just a tiny bit lower. But this is all based on the nature of the test. It's not based on, mortality outcomes or anything. And I think this was particularly impressive. The rate of unnecessary extracolonic findings, 40 to 70%. That's really high. Somewhere between 5% and more than a third result in diagnostic follow-up and 3% require definitive treatment. So, none of these other screening tests are going to have any of these kinds of complications. So, yes, it's there, and, we'll talk about where they recommend it, but it's a whole separate category of, extra complications you can have from this procedure that's entirely separate from any other screening method. Then there's the serum test, which this is the step 9 DNA test that detects circulating methylated step 9 DNA. The epiprocolon is the brand name. It was just approved in April of this year. basically it's not that great. Its sensitivity is 48% for cancer, but it's a blood test. You know, in terms of the level of intervention for people, this is pretty low. So the barrier to entry to actually getting someone screened is relatively low. And so, you know, in terms of timing, what do you do with these tests? When do you start? How often do you do them? When do you stop? So when to start, as I was saying earlier, age 50 is a pretty clear declaration. This was basically based on when they calculated out based on population data, based on these tests, where you're going to have your highest yield in the test. 50 is what they came up with originally, you know, decades ago. And they looked at it again. They tried to do a fresh set of, you know, analyses, and they tried to look at age 45 as maybe a new start time, if that might work. And they basically, and the problem is the complication rate goes up if you start earlier because you're going to have more colonoscopies, more screenings, more complications. So they looked at, well, what if we sort of do a 15-year interval follow-up, say, on colonoscopies instead of 10, so you have the same lifetime number of colonoscopies, but you start earlier, will that be better? And they basically said, well, some of the tests showed it might be beneficial, others didn't. So overall, let's just stick with 50. And that's pretty much what they came up with after a long series of mathematical analyses. So they're sticking with 50 for when to start. Obviously different if you're not an average screening population person, a strong family history, that sort of thing. This is just a standard population. And then how often should you do it? So, and this is where they came up with their standard for the most recent test, is assuming colonoscopy is the gold standard based on mathematical modeling, again, because there's no randomized controlled trial showing this, which tests are going to be within 90% of the life years gained. So, again, I don't know the exact number, it's somewhere in the range of 237 or 240 life years per, 10,000 screens, or something like that. And so, which tests are going to give you similar rates of life year benefits? So, this is what they came up with. Basically, there are the best options: annual fecal immunochemical test, the FIT plus every 10 years sigmoidoscopy, and this is every 10, not every 5, which old ones have been every 5, 10-year colonoscopy, or 5-year CT colonography. And they put that among the best options because they felt like, based on modeling and based on what data we have, these were within 10% of each other in terms of how effective it was. Less good just doing the FIT DNA every 3 years. Like I said, it's a newer test, and it's sort of, how often do we even do this? They approved it for 3 years. They really don't even know exactly how often you should do it. Doing a FlexFig alone every 3 to 5 years, so no FIT with it. And then the high sensitivity guaiac fecal occult blood every 1 to 2 years. And then there's sort of the only if you have to test, the F9, mainly because of that very low sensitivity under 50%. So this is what they came up with. And then when to stop, definitely reduce benefit after age 75, especially if they've already had adequate screening. Basically, probably don't screen after that age unless they just never had a colonoscopy or other screening. And then little benefit after age 85, mainly because of that 10-year effect and whether they're really going to benefit from these low-grade cancers being screened. So how is this different than the old guidelines, which are from about 8 years ago? Back then, what they recommended was colonoscopy every 10 years, the same. Annual FIT, still on there. Annual GFOBT, that's kind of on the less preferred list now. And then FlexFig plus GFOBT, they've flipped that around entirely, and now they're saying, yeah, you can use the FlexFig, but with the FIT, and do the FIT every year. And then they added in the CT colonography as being something they recommend. But really the big change, and this is, sorry, I'll mention some of the other recommendations, because everyone has to have something to say, right? So there was this big group of a bunch of things, including the Society for Gastroenterology in 2008, that came out with sort of a similar recommendation. They said, FlexFig, colonoscopy, barium enema, which has now dropped off the USPSTF radar entirely, and then CT colonography every 5 years, they're preferred, and then FIT DNA and fecal occult as other options. And then shortly thereafter, the American College of Gastroenterology came out with, surprise, a recommendation that colonoscopy is the single preferred screening strategy. And then if it's unavailable and acceptable, we can use FlexFig or CT, and then some of the other ones are sort of secondary options. And then in 2012, the National Comprehensive Cancer Network said colonoscopy is preferred, but you can basically do the other things as secondary approaches. And then the American College of Physicians, who presumably represent us last year, came out with either annual fecal occult blood or FIT, doing just a FlexFig only every 5 years, combining FlexFig with some combination of fecal occult or FIT, and then colonoscopy every 10. So it's kind of a smattering of recommendations. I think that's what the USPSTF is trying to reconcile is, you have all these recs, you have all these tests, what do we do with them? And so in terms of resources you can use, They had some handouts. This is in the issue of JAMA where they published this back in June. I wouldn't call them the most patient-friendly in terms of, 7th, 8th grade education level, but they're okay. It gives you a set of the tests, and it tells you what is colon cancer and what are the things you do to screen them. So in terms of what can you give that actually represents the current guidelines, there are these places to start. It's in JAMA and pulling off the web. Ultimately, what they say is the best screening test is the one that gets done. And so at the heart of their recommendations, they essentially deprioritize it. They don't say colonoscopy is number one, or we have 4 preferred tests. They originally were going to. When they had the sort of temporary guidelines last year, they had them out saying, well, we might do these as preferred and these as acceptable. And they got a lot of feedback and forums basically saying, if this is too complicated, let's keep it simple. And so this is what they came up with. Is a third of people aren't getting screened. Let's not hold out the candle for colonoscopy. Let's get them a screening test they're actually going to get. And then that may be a spur where if they need more advanced screening, we can say, well, this is abnormal. Let's go there. What it made me think of is, I don't know if you read George Orwell's 1984, but, the animals initially have these 7 commandments they come up with, which are, 4 legs, not 2, and that sort of thing. And the final one is all animals are equal. And then the graffiti at the end is, but some animals are more equal than others. And so the guidelines sort of remind me of this, and this was a Mac error. The font was supposed to be kind of a chalkboard font. But anyway, basically what they're saying is all the tests are equal. We're not going to formally recognize any as better than any other one. But if you read our paper, really get these first. Annual FIT plus 10-year sigmoid, 10-year colonoscopy, or a 5-year CT colon. If they won't do those, try these, either fecal occult, the FlexSig alone, or the FIT DNA. And basically, if they literally won't do anything else, but they're willing to get a blood test, hey, it's better than nothing. And they don't even talk about the variant amount. So going back to our cases, 58-year-old African-American male, history of diabetes, comes in for physical, never had a colon cancer screening. What do you recommend for this guy? Probably one of those 4 tests. So, you go back here, FIT is fine, colonoscopy is fine, CT colon's fine, FIT plus sigmoidoscopy. Honestly, the standard, especially if you look at the other groups and the fact that they, flat out say we consider the colonoscopy the gold standard, you're still going to recommend colonoscopy first. But, if they're not willing to do it, those other tests are viable options. They're better than nothing. So that would be the recommendation. For the 76-year-old white female who had colonoscopies every 10 years starting at age 50, what they're basically saying is, look, this person's been screened, probably by their, lifespan, they aren't going to have likely more than 10 years left. The benefit of doing additional screening at this age is probably minimal, probably avoid it. It's probably not worth the harm. For the 78-year-old Native Alaskan male, I mentioned that just because Native Alaskan is one of the groups that has a higher mortality from colon cancer, who's never had a colonoscopy. They're in that gray zone, but this is someone who I might think about mentioning colon cancer screening. And again, it's not just colonoscopy. They may come in asking about that. It's, whatever screening is palatable to them. You have to sort of work with them on what's best. And then for the 86-year-old who had 3 normal colonoscopies, probably no benefit there. They're probably old enough that they're more likely to be harmed than helped here. So that's all. Any questions?
Let me unmute everybody's phones here. So, Aaron, could you go back on your slides to this? Yeah. So that second case, the 76-year-old, so that's a scenario where their colonoscopies have been normal completely. Now, if they had polyps, you continue to do screening tests post 75 years of age or on if they had. Do you have any opinion about that, or is that more really kind of leaving it up to the gastroenterologist to discuss? It's a tough one. I mean, I guess it would depend also what their most recent colonoscopy showed. If they had an abnormal in the first. But yeah, I mean that's a tough one because they had them every 10 years. Her last one was 6 years ago. She presumably wouldn't be due again for another 4 years if she was going to do the 10-year follow-up. Then you're talking about an 80-year-old getting a colonoscopy. I don't know. It's a tough one. The same thing is true for this FIT DNA, by the way. No one knows what to do with it because what if it's abnormal? Like you get the FIT DNA. The FIT DNA has the tests for blood, plus it has the test for these DNA sequences in cancer. So let's say the DNA is abnormal. You got cancer DNA showing up on your test. Then you get a colonoscopy and it's normal. What do you do with that? Do you follow up in a year? Or do you just do normal 10-year screening? no one knows what to do with that. And I think this is a tough one, too, where, if they were big polyps and they had to kind of worry about another one, but...
the FIT DNA is the Cologuard. Is that kit that you order in the mail? That's what the FIT DNA test is?
I forget which one Cologuard is.
Does Cologuard fit into, do you know if Cologuard fits in any of those categories?
I think that's it. I'm forgetting the brand name on that one.
Okay. Because I think with that kit, you send a sample where they test for blood, but they also do the DNA test.
Yeah.
That must be the FIT DNA
Yeah, that's
test.
right. Yeah, that's the DNA part.
Okay. Well, I really, before we open up to questions more broadly, I really enjoyed your title. Being a 46-year-old, I'm sort of starting to stare my first colonoscopy in the face here, and a broader scope is what worries me. That's what.
It's the same size.
Was that intentional? Was that an intentional title? You just laughed. All right, let's open up to questions.
So oftentimes we have patients actually, everything was okay, and the patient still wants to get it after age of 75. So for my practice, I hope so many years to recover from it. And sometimes the 80-year-old feel like everything's fine. The patient says, I want to get my colonoscopy.
Yeah.
The patient preference is very do you guys order that? If the patient
I would say, well, first of all, I'd say that's a rare case that someone's asking to get a colonoscopy.
I know.
But you're right. Some of them really feel more comfortable with that. I personally dissuade them if they're over the age of 85 and they don't have any major risk factors like prior colonoscopies. If they're now, I could see myself with some of these patients of mine that have just great longevity, and you're like, yeah, you're going to be around here when you're 100. I could sort of see myself entertaining it, but I would probably try to dissuade them from getting a test just because it's fairly invasive and it has some risks. And the risk does go up, right? The older you get, the risk of perforation, I think, is mostly in the elderly.
Yeah.
It's thinner like anything else. It's thinner like the muscle.
Yeah.
Yeah, everything's easier.
Yeah, but I do have a patient like professor, lawyer. Ask for this.
Are there any other questions that folks on the phone might want to ask Aaron? Nobody? Okay. Well,
I sent a question on chat, but can I ask it now?
Absolutely.
Thanks for the talk. I was wondering, Aaron, have you been ordering the FIT testing, and have you found that insurances are covering it? And also, how do I order it?
No, I actually haven't, and to be honest, I personally push colonoscopies. Now, whether that's appropriate with the current guidelines, I don't know. No, I haven't really had to deal with it yet. Most of my people have been getting colonoscopies, or say they will anyway.
I'm forgetting, but I thought we replaced the Hemocult test with the FIT test. Don't we do that? I think when you order, right?
You can still order it.
No, because my patients are still coming back with the stool cards, like the ones who refuse colonoscopy. And so I think FIT would be just a great option for the ones who don't want to do colonoscopy.
I've looked into this, actually trying to get a clear-cut answer, and have not found a great answer for actually getting this accomplished, ordering a FIT test. And I've been trying to talk with some of the gastroenterologists to figure out an easy way. So I do not have an easy answer. Despite, if somebody else knows one, I'd love to hear it.
Well, I think one of the benefits of having these discussions when things like this come up, we can pursue it after today. We can find out and give folks a solid answer if they want to order at their local clinic and get the supplies to guide their patient. I think that's something we can definitely look into. I think you bring up a really important point that, sure, we're going to probably most commonly recommend colonoscopies, but there are so many patients that just visit after visit decline to get cancer screening because the conversation is so focused on colonoscopy, meaning colon cancer screening is synonymous with colonoscopy, and it really doesn't need to be. And there's a lot of folks that, in my experience, have passed on colonoscopies for 5, 10, sometimes even 15 years, and then you have a detailed discussion about what a sigmoidoscopy entails and maybe a FIT test plus a sigmoidoscopy, and a lot of those folks will change over and start rethinking. I've even had patients that if I sort of open the door to their minds to think, okay, I'm going to get this test, And in the end, they ended up getting the colonoscopy, but it was almost like the discussion about alternatives opened them up to the discussion. They almost initially would shut the door on the discussion because, and it's usually the prep that worries them so much, right? It's really, I mean, there's an ick factor to the test being performed, but most people have heard through word of mouth how bad the prep is, and that's what gets passed on from family member to family member and friend to friend. And I think if you can somehow open that discussion up, you'll have a lot more success. And I appreciate you putting these other tests up there, and especially with the guidelines supporting a broader discussion. That's great.
I just want to say that we did order the Cologuard for one of the patients for a resident. It's covered by Medicare, so I would assume a lot of the managed care would cover it if Medicare covers it. Cologuard's the only one I believe that's approved, and it's a paperwork that they have to fill out, and the provider fills out and then gets mailed in.
Yeah, Aaron, you've ordered that once on one of your patients, haven't you?
Actually, I haven't.
Oh, I thought you did on the Cologuard test. Yeah. That, I mean, you can watch online how the general process of getting somebody that test. Any other questions?
I have a question about the prep, because I agree with what you said, Niraj, that often the barrier is the prep, and you'll order the colonoscopy, and then a year later they won't have done it, and you order it again. Is the same prep necessary for sigmoidoscopy and CT colonography? Because in that case, I typically go right to annual fit testing.
Yeah, I mean, you can do the CT without prep. There's definitely a less extensive prep for sigmoids, but it seems like it doesn't work as well if you don't do the full prep.
So I'm sorry, say it again. So you can do a CT colonoscopy without any bowel prep?
You can. It's not as good, but they did look at, how effective it is without it. It's just not as effective.
And then you mentioned the sigmoidoscopy with a prep. Did I mishear you?
Mm-hmm.
Some people recommend a full go lightly prep.
It wasn't a full go lightly prep. They did recommend some preparation in terms of diet the day ahead of time.
Okay, right. It's diet and enemas the day before, right?
Yeah.
The morning of.
No, not the go lightly prep. That's just
right. Okay. All right.
Specialty reserved for colonoscopy.
Is that what you're asking?
Exactly, because if I could, I might be able to get them to do one of the other alternatives if I can convince them the prep is different. But I usually hold out for the colonoscopy and use the FIT as my alternate.
I understood.
Yeah, and that was something that the USPSTF would agree with.
Okay. Well, I'm sure Aaron's happy to field any other questions that folks might have after today's discussion. My takeaway is to look into the FIT test, how it's ordered, and at least open up that option so folks can reach towards that sigmoidoscopy and FIT test alternative. So great. Thank you so much, Aaron, for joining us.
Thank you.
Thanks, everybody. There it is.